Well, hello everyone. Thank you very much for joining us. This is, I have to say from the start, this is something of an experiment to see whether this works, but we're really delighted that you've managed to connect here and get onto this open forum. And the idea today is to see if we can together talk through what everybody has planned for implementing research during this, what is now a global pandemic, and we hope we can really implement a strong research response together. So I'm not going to talk for very long at all because I want to pass over to the panelists we have. The idea is we've just got a few people to initiate discussions by explaining what they're doing in their countries in terms of research and what they see the gaps and the challenges might be. We're also joined by the team from ISARIC who can tell us more about some of the tools and resources that are available already, which are really perfect starting points. But really we want to put most of the time to having an open discussion and hearing from you, telling us what you're planning to do, where we can share resources and tools and what the gaps might be. You'll see on your screen that there's a button in the middle of the options that says Q&A with a message on it. If you, even from now, if you begin to type in anything you want to add to this, if you want to tell us about your experience, tell us what you've got planned, highlight gaps already, or put a Q&A in as the panelists are talking, and please use that because we can begin to collect those whilst the others are talking. I'm sure we won't have time to discuss everything today, but we can certainly keep them going, and we hope this is just a starting point because we had so many more people subscribed than we had space to fit onto the call, and we've also got another call at 3:30 this afternoon, so we can amalgamate all these amazing comments. So I'm going to hand over to some of the panelists now. I'm not sure that we put these names up of people that were able to talk, but this is obviously in this context it's been quite last minute. So we'll have Charles and Pei-Kyong to start with, and then we'll see if we have any of the others, but we do have the ISARIC team as well, which is fantastic. So I hope that makes sense to everybody. This is a bit of an experiment, but please join in shortly and begin to put your questions in. But please let me hand over to Charles, who's joined us from Kenya, who's going to give us an overview of their plans and what's going on in Kenya. Thank you, Charles. Charles, are you ready to speak?
I'm getting ready.
Screen share.
Have I shared the screen now?
Yes, please. Yeah, if you share the screen, and then we're over to you.
My IT expert is fixing that. Just a minute. Share the screen. Sure. Can you see our screen now?
Yes, we can, Charles. Over to you. That's great. You can run it like a normal PowerPoint slide.
All right. Oh, great. Sorry for that. So I'm Charles Agoti. I work at the Cambridge Welcome program here in Kilifi. Mostly my strength is in molecular epidemiology. So I'll take you through a couple of things actually we've been trying to put together to respond to the now pandemic, and also share with some news actually, which I think some of us might be aware about already. To date, actually, we have 13 African countries which have reported the COVID-19 disease, and the latest one being our own, Kenya. Actually, about an hour ago, the minister reported that we have a Kenyan citizen who's just returned from the USA via London, who is tested positive. That was last night. So the meeting becomes really very timely, this meeting, in terms of trying to link up with everybody, including you guys at Oxford and everybody around the world, to try and put together the best response. Just a bit more about Africa. So this is the first case, actually, the Kenyan case in East Africa. So as you can see, most other African countries, especially North Africa, not most actually, some African countries, especially North Africa, had detections, and Egypt is leading in detections. So we don't know whether this first case has had a local transmission, but we are aware that this is somebody who arrived in Kenya on the 5th of March, and the detection was following the self-presentation for testing. To my next slide, the response so far has been actually the government at the beginning of this month, through a presidential directive, ordered the preparation of quarantine facilities, and so far we have one that is ready, 100-bed facility. So it's definitely not so many people can be quarantined in that facility. So hopefully people will self-quarantine in case of major outbreak. But this will be like the severely ill. But also the counties across the country, 47 of them are involved in preparation of similar isolation facilities, including Kilifi, where I am based. So in terms of diagnostics at the moment, not so many places around the country can test, but those that can test at least are the National Public Health and Health Laboratory, CDC Kenya, and here the Kemri Wellcome Trust Kilifi also we can test. But all positives need to be confirmed by the National Public Health Laboratory before they can be communicated. So there has been quite an amount of public sensitization. The ministry has now toll-free line, and as well has SMS system to inform citizens of where an outbreak might be ongoing or may be starting. And also media has not been left behind in informing, and there are banners in major places, but not so many of them. You have to at least walk around a bit more to find one. So there is a travel advisory in place to China, to Italy, and actually as of today, no international meetings bringing together more than 15 people or 35, I can't remember well, but international meetings generally have been discouraged. And actually, public gatherings actually following this morning's public press conference has been banned actually, so no public gatherings are allowed at the moment. So there are case investigation teams both at the national level and at the county level. But given that this is a new outbreak, they're also learning on how actually to do proper investigations. So this is our setting. I'm just giving a picture of our hospital setting here in Kilifi. So this is how we see patients coming in. As you can see, this is something which I will talk about later. Our hospitals, given the numbers they have to handle, we don't have so many facilities around the country, will be both important in responding to the outbreak, but also have to be considered as a potential risk of spread if people are coming in with other infections, and there is people in the midst with this contagious infection. At the Kemri Wellcome Trust program, and we have been involved in response. Actually, we have had a group studying respiratory infections for the last 20 or so years, led by Professor James Knox. And in a way, we have some understanding of respiratory infections, how they spread in the local community. We've been engaging also in studies across the country, but they now seem much more important than they have been actually before. So also we have a team looking at actually in immunology studies. For instance, we have involved in an application that went recently to the Wellcome, trying to look at pre-existing immune responses to other coronaviruses, how it will impact this current outbreak. But also there are studies planned around doing field epidemiology, that's looking at different health facilities in a defined population to define incidents and other things, but also importantly to pick up cases which can be followed down to the household level to understand actually important contacts and how much a transmission occurs at different risk settings, especially the households. And where from our previous studies we've observed that respiratory infections quite spread within households. I'm particularly speaking about our past RSV studies, for instance, which have tried to infer who infects whom in a household. So also we actually considered at the moment, and we have been involved in other studies which are trying to prepare us to be a molecular virology stroke epidemiology hub for East Africa. There is actually a grant held by also Professor Knox, which is trying to look at across East Africa, how can we get capacity in genomics and in diagnostics that is relevant to public health and to epidemic response like this one. Finally, on the research priorities, definitely there is a lot of activities that we've planned, but also there are activities potentially that we can be involved in, all actually need to be planned, all need to be done. For instance, in this kind of a setting where surveillance is fairly not very strong nationwide, we can say in Kilifi we are much better in surveillance, but I can't say that across the country. So it will be quite a process and a job to define the size of the epidemic and pandemic if it occurs, if the infection comes into the country, which has come to the country, spreads widely. I'm not sure that we have at the moment good facilities which can measure the size of the epidemic and the impact of the pandemic. And also the diagnosis centers, as you realized from earlier on, they are quite limited, and accessibility to diagnosis, I think, is a major challenge. I'm thinking of all areas across Kenya, from western all the way to northeastern, all the way to western, all central. At the moment, the case definition is that you must have a travel history. But what if the infection is already taking foothold in the country and people who have ARI want to be tested? I'm not sure that there is a lot of accessibility to diagnostics at the moment. Not to say about the kits, not to say about the deficit in personnel. And also, in terms of characterizing the epidemics, I'm pretty confident that if an epidemic occurred in coastal Kenya, our proximity here might allow us to characterize it properly. But if there is hotspots across the country, then we are a bit distant, and we need somehow to have a way that we can actually characterize transmission hotspots across the country. I'm thinking about what are the other areas where the epidemic can take foothold. We know, for instance, at the moment, church services are still happening despite this morning detection. So that poses a risk, and I feel like there needs to be more efforts to be able to characterize local hotspots and give timely warnings. In terms of control and treatment, I think generally around the country, I happen to be sharing office with the doctor, and there is kind of like, there has not been clear how the treatment for this infection needs to be approached. And I think it's a risk to health workers, all of us know about that. And I think that there is a serious gap in terms of clinical management, and also at the health centers where people are coming to get treatment, what's the risk there? And definitely Africa, I think, is one of the places where we will most need this vaccine if the infection arises, because we do know the burden of illness is already very, very high. Adding another one on the table, it's going to strain. I don't think we have enough ICUs, for instance, to take care of the critically ill. So I would like to stop there and saying we definitely want to get as best prepared for this as possible, and have to say thank you to the organizers for bringing us on board, so that at least we can share notes on how to best give response and also identify priorities.
Thank you, Charles. That's brilliant. Yeah. Thank you very much. We'll move on, because we can get some responses in the Q&A. So just to point out to everybody on the call, if you look on the bottom of your screen, it says Q&A with a little message bubble. Please type in your questions for Charles, because I think he's raised some excellent points that I think will translate to lots of people, especially around not getting left behind in research, difficulty on reaching places that are more remote. Lots of really excellent points, Charles, that I think you're thinking hard about, and will be the same for many groups. So please, can I encourage you on the call to post your questions to Charles in that Q&A piece, and we'll pick them up in the discussion. Pekyon, can we hand over to you? So Charles, can you if you can stop screen sharing, we can swap quickly over to Pei Kyong, but that was brilliant. Thank you.
Yep.
Excellent. There we are. And stay online because we'll be coming back to you in the open session in a moment. Pei Kyong, are you ready to go? So you need to do, that's it. Brilliant. So
yep.
Over to you, Pei Kyong. Is she still with us?
Can you hear me?
Yes, loud and clear. There
Okay. All right, great. So I haven't got slides, but just to share that we're planning a prophylaxis study with healthcare workers. It will be a placebo-controlled study. It's registered on clinicaltrials.gov now, and the protocol will be published soon. So, so the study is a prophylaxis study. We don't have any treatment studies in the planning. So apart from that, I and my team are planning a survey and some qualitative studies around impact on travel restrictions and social distancing, etc. So the focus of I'm just going to zoom in on one aspect of the clinical trial. We will be conducting a series of patient and public involvement workshops and interviews with different groups of stakeholders. And the first one is potential participants, which is in this case is hospital staff and people working in high-risk areas. So hospital staff, healthcare workers, maybe cleaning staff, etc., and members of the public via existing public advisory groups, such as the existing community advisory boards. And we've got a Bangkok Health Research Interest Group just started. So these workshops will be conducted at various stages of the project. The first stage is during the protocol development stage and prior to study start. The second is soon after study start, and the third is after study completion. So the first stage, which is prior to study start, we will be talking to them, these advisory groups, to inform the study design, procedures, and to help us with our participant information materials, to seek general attitudes about the study, the use of placebo and study procedures, to develop communication materials for dissemination to the wider public and media about the study. So how best to communicate the meaning and rationale of placebo, of blinding. So it's a double-blind study. To identify what could motivate or discourage those who meet eligibility criteria to join the study. To develop, to determine to what extent, so the drug is chloroquine, is available from local pharmacies or informal vendors. So we also develop FAQs and posters for information for participants and the public as well. And then soon after study start, we'll do another participant involvement activity to identify any challenges to recruitment, procedures, and understanding of the study and potential solutions. And then after the study, we will do a series of public and patient involvement workshops again to help us disseminate the study results and to inform strategies for dissemination of study results to the wider public so that they can use the results as they see fit. That's all I have actually, so thank you very much.
That's lovely, Pei Kyong, and I think that's really excellent to bring in this different element of research that obviously needs to happen hand in hand in terms of doing some social science work around this. Okay, perfect. Well, I'm going to hand over to the ISARIC team now. We've got Antonio online, who I think is going to take us through the wide range of protocols and resources that they've got available. So you need me to stop sharing my screen, and I'll let the ISARIC team pick this up. Thank you, Pei Kyong.
Okay, Gail here. Can everyone hear me?
Loud and clear.
All right. Hi. Thanks, Trudy. Well, hi everyone. I know some of you, and hi to the others. So I'll start off as the ISARIC team from the Global Coordinating or Support Centre in Oxford, and apologies for not having any slides. But we are a federation of clinical research networks. Some of you are already members, and we certainly are happy to welcome others, of 45 clinical research networks networks covering over 130 countries across the world, previously having responded to outbreaks such as Zika and Ebola. Regarding our COVID-19 pandemic response, that actually kicked off in January when, with the help of our Chinese collaborators, revised our clinical data collection form, which is available via our website, either as an electronic case report form, or you can get access to the REDCap file and run it locally yourselves. But really that's about facilitating standardized clinical data collection so that we can, as a community later, pool the results and as quickly as we can try and inform patient care and policy. That same case report form is the one that's used on the WHO clinical data platform, available on the WHO website, and certainly what the Ministries of Health have been asked to complete through the international health regulations by the WHO. In addition to that, we've got our clinical characterization protocol, which is essentially a natural history protocol with the option of biological sampling, depending on what resources you have available. And we've got a number of partners who are running with that across the world, including, for example, colleagues in Malawi. And so I'll hand over to Tony about that in a minute in case she wants to say a few things. We're also involved with either supporting clinical trials. For example, we provided some support to some of our Chinese colleagues, and Peter Horby is in charge of going to be leading on clinical trials for ISARIC going forward. There is a WHO master protocol, and there's going to be a revised version of that called the core protocol. The master protocol is available on the WHO website. I believe it's a little bit tricky to find, and I will give them some feedback on that. But also on the WHO coronavirus website, it is worth looking, if you've not already looked, for guidance on ranging from infection prevention and control to home care to some early investigation epidemiological studies if you find yourself in a country where you're at the earlier stage of this pandemic. So Tony, I don't know if there's anything you want to add about what you've been doing with regard to the CCP and in particular colleagues in Malawi.
Thanks, Gail. Hi, everyone. I'm Tony Ho. I'm a clinical senior lecturer based at Glasgow University and a member of ISARIC. I've previously worked in Malawi coordinating kind of observational studies on influenza, and have been working with the Malawi Ministry of Health as well as the Malawi Liverpool Wellcome Trust Clinical Research Programme. And they're just in the process of setting up COVID-19 surveillance and hoping to use the CCP. I guess the thing to highlight is that the CCP form, the data collection form, in its current form is quite a lengthy form, that a lot of it might not apply to lower middle income country settings, as Charles highlighted, without a lot of the kind of intensive care facilities, tertiary care facilities. So we've made a kind of pragmatic 3-page form that is kind of abbreviated, which I think will reduce the burden in terms of data collection, and that has been submitted to the WHO for approval. And I think Clemens Masesa, the data manager for MLW, might be on this call as well. But we're trying to apply for national approval to use the CCP protocol, so that in Malawi, so that we can compare it within different sites in Malawi, but also between different African countries. I know that Uganda, the UVRI, also use an adapted form of the CCP as well. So that's really all I wanted to add.
Thank you, Tony. That's super helpful, and I think we're really beginning to build this idea of how countries getting ready to do surveillance to detect, and then disease characterization to understand, and then moving into thinking about what clinical trials could happen to assess maybe therapeutics or supportive care. I think we're able to move on to the question session now. I've got a few written down. We've had several come in. Dorcas is on the line and she can speak. Dorcas, I know you've got a question to put around this. Could if we'll give the floor to you to set that discussion. Over.
Hi everyone, thank you so much for setting this up today. So I think I posted around 2 or so questions. Dorcas Kamuya, I'm based at Kilifi in the same program with Charles. And some of the questions are around, first of all, the effectiveness of the preventive measures that have been, proposed and that have been encouraged, because those are questions we are getting a lot. How effective is sanitizing your hand, wearing the masks? And those are questions that are coming from the population. We don't have data to back up that. And I was wondering whether that is part of what is being looked at. The other question is around preparing communities for clinical trials which are happening in this pandemic situation. In addition to the preventive measures and explaining what COVID is one thing to have that information. It's another thing to know that this is research, this is a clinical trial, there's placebo within it, or there are therapies that we don't know how effective or even if they are efficacious. How best can we set up systems that can quickly respond and prepare communities for this? And I'm raising this knowing that we can learn a lot from what is happening with Ebola, with what is happening in Zika. And there's some protocols that can already be circulated across the countries, across the world, so they are easily accessible. People know how they can quickly roll out this. Yes, those are some of my 2 ones.
Dorcas, that's really helpful, thank you. And I've got some questions, I'm looking at the questions that are coming in. So that's a really key question. Are there community engagement protocols that people are using that we could roll out widely? So we'll put those. Now, just for all the participants, if you have a look on the top of your screen, you can see, or it might be on the bottom, wherever the toolbar is, you can see there's an option for you to raise your hand, and that means if you raise your hand, we can give you the mic to speak. We've got lots of questions coming in through the Q&A, which is brilliant. So type those in, and then we can pass it to you. So I'm just going to put some of these questions coming through to you, and it would be brilliant to hear from you on the call. So it's not just all of us speaking. So here's some things that are definitely coming through from discussion. Surveillance studies. It'd be really good to know anybody on the call who's involved with surveillance studies in their countries. I know we've got people on the line from Mali, from I think there's Uganda and Malawi, Asia. Obviously, we've got people here from Thailand, and I think maybe Bangladesh. So it would be great to hear anybody's experience so far setting up surveillance, surveillance studies, but also surveillance for detection, which would be people really want to know about. The other question is around protecting health workers. What's being put in place to understand that, and then lastly, some questions around measures to be put in place in different countries. So if you are keen to answer any of those points, please raise your hand and we can give you the mic. While we're waiting for that to happen, because we can queue those, can I turn to the panel members to pick up any of those questions, because you've got the mic already and we can hear from you straight away. So I don't know if Charles, Pek-Yong, Gail, Tony, I'm sure there's some of those that you could pick up. So what do we know about what surveillance studies are happening? Does anybody know any of community engagement protocols, and then measures for protecting health workers and studies around that? Over.
If I may just, Trudy, again, ask, and great questions, Dorcas, ask people to start off by looking at the WHO coronavirus website. That's the WHO Geneva website. There is a host of study protocols there, whether it's ranging from the epidemiological investigations through to healthcare worker studies, including advice on how to keep your healthcare workers safe. Certainly stepping back from the research, and just to reiterate the key messages that Dr. Tedros, Mike Ryan and Maria Van Kerkhove on behalf of the WHO community emphasize every day on their press conferences, is the importance of aggressive containment and contact tracing. And in the terms of aggressive, I mean, you know, that you try and identify every case and follow up every contact and isolate and investigate where appropriate. And again, there's advice available through the WHO, and every country has a WHO country office to follow up and advice from that. There is a WHO China mission report, which is about 20 pages long, but it has lots of good information in it about what happened in China. What you'll start to see is that slightly different techniques have appeared to work regarding how to try and lessen the epidemic curve, or at least the first peak, in some of the countries, where China did apply fairly severe containment and lockdown measures for the communities, certainly in the Hubei province where Wuhan is situated, whereas South Korea have applied more community engagement with very extensive and aggressive community testing, and that seems to be bending the curve for them. And each country will probably, to a certain extent, find the fit that suits for them. As we're still trying to establish the global case fatality rate and trying to avoid this virus becoming established in our naive populations around the world, again, I come back to the need for containment and contact tracing. And so GoARN is rolling out through a number of countries their contact tracing tool called Go Data. So I've probably said enough there. Over.
No, Gail, that's brilliant. And I think we can't emphasize enough how powerful and comprehensive the tools are on the WHO website. We can highlight some links, but I think we urge you all to just have a search around them. There are so many, it's sometimes slightly difficult to find what you need, but they are separated well into, as Gail described, tools for doing case detection and containment. The surveillance tools are there. And so that's all really excellent, good advice for this sort of public health response. So we all urge you to look at those. What we'd really like to focus on here is how we support together in moving into doing research. And this is about research preparedness if you have lots of cases in your countries, because part of the drive for this conversation we're having today is around making sure that access to evidence and data is equitable and that everybody has a chance to take part in research. And so sometimes some places need more support than others. We heard from Charles earlier about how they're concerned if they have lots of clusters of cases in remote places. So there's obviously lots of challenges there in terms of even putting the initial public health response into place and then following that with research. I'm really keen to hear from some of the participants. Alex, I don't know, I can't see on my screen if we've got any hands raised, but I don't know if anybody is coming forward from the audience that wants to take any of those. Another couple of questions coming through about therapeutic possibilities for trials. Chloroquine's been raised. I've read about that somewhere else as well. I don't know if anybody's got any studies going on or indeed any evidence about Charles might be able to answer us this, the sort of the antiviral properties of chloroquine, and whether it's, you know, repurposing existing drugs is a really good head start. And we've seen lots of those studies. We've put that up on the COVID area on the Global Health Network, what clinical trials are happening already. So if there's any, it might be an interesting brief discussion about therapeutic possibilities. And I might turn this one over to you, Charles, or Gail as well, because obviously that would have been talked about at WHO. So Alex, can you tell me if there's hands raised, or otherwise can I turn to Charles and maybe anybody else who wants to talk about therapeutic possibilities? Over.
Hi, Trudy, Alex here. I know Ambrose has had his hand raised, so we could turn it over to him to ask a query.
Please, yes, let's turn to
Ambrose. Ambrose, I'm just going to try and turn you on. If you can speak, great. Otherwise, we'll address it by the Q&A.
While we're waiting for Ambrose, it'd be great to have feedback on those therapies. Oh, here we are. Ambrose, over to you.
Thank you, Trudy, and thank you to the organizers for organizing this very important forum. I am from the Kemri Wellcome Trust Research Program, like Charles and Dorcas, who spoke earlier. And I, like others, think this knowledge sharing will be a vital strategy for the response, especially given how rapidly this pandemic seems to be evolving. I just had 3 points, and largely around approaching the pandemic from a health systems angle, recognizing that, especially in many low and middle income countries, whatever we're proposing to be delivered, whether research or interventions, are being likely to be delivered in fragile health systems. So I think my first point would be that whatever research being proposed, as much as possible, should attempt to align with the national, regional, and global response. So ensuring that we engage at our local levels and attempt to feed into the response directly with policymakers working closely with us as researchers. Secondly, I think there's an opportunity here to ride on the attention generated by this pandemic to strengthen capacity for conducting research, including trials, strengthen our routine surveillance infrastructure, and our general epidemic preparedness and response. So thinking beyond just COVID-19 and thinking long-term, how can this then transform our capacity to address future threats which will inevitably arise? And then finally, reflecting on our role as researchers in sharing facts and preventing misinformation and panic. I think some of the questions which Doc has raised are challenges to us to look beyond our areas of expertise and help in information sharing. Thank you.
Ambrose, that's brilliant, really well put. Thank you. And I urge all of your calls, think about if you can respond to this. These points he's raised. I think this point of implementing research in fragile health systems is absolutely fundamental here, and this is really why we initiated this this open workshop. How do you implement research protocols in places with difficult health systems and also perhaps limited research experience before? So very, very key, and really keen to hear from people about what they think their gaps might be. Following on from that, again, we're hearing this call for strong public and community engagement in research and ideas around that. I can see Nashon has raised his hand. Can we hand the mic over to Nashon, please? And then whilst we do that, if there's anybody who has any more comments from some of the other points raised so far, especially about potential therapeutics that might be worth evaluating. Nashon, over to you.
Hi guys, can you hear me?
Yes, loud and clear. Go ahead.
Okay, thank you very much. I'm called National Winner. I work with Kenya Red Cross. From the recent statistics, we've been hearing that the said virus is now being declared pandemic in the world. And with that coming, we've heard of statistics of the people affected or rather infected with the virus, and the same people, we've also heard that among them, there are those that have been declared or said to have recovered from the virus. I'd wish to know through what means were these people actually declared recovered? Were they put under treatment or what? And then secondly, it's a very good initiative that we guys are trying to put across, and I really want to be part of it. So if we can be given steps or a means in which we can join in the research, it will really be a privilege. Thank you. Over.
Thank you, Nashon. That's really well put. So I think you were asking, of the cases that are detected, then how are they then declared to be virus-free? I'm going to hand that over to Gail to give us a sort of global response on that, but also perhaps Antonia too, but also Charles might be able to give us more of an idea of how that's happening in Kenya. But I think we need to think about this in the global context as well. And because there are many questions around this that keep coming up. Gail, can you pick up on that one for us? Thank you.
Yeah, I'll try my best, because to a certain extent, it's because this is a dynamic situation, then there may well be different approaches that will be applied depending on the phase of the pandemic that the country finds itself in. So again, I know I sound like a broken record, but again, on the WHO website, there is clinical and IPC guidance, and certainly for those countries that have been able to do it, where they've had laboratory capacity and been able to hospitalise patients, whether they've been the milder spectrum of the disease, and there is a spectrum of this disease. And thankfully, we think, or we're pretty confident, the majority of the cases have what we would call mild infection, and many of them will never require hospitalization. Now, as we're learning more about the prognostic factors for severe disease, which we understand them to be increasing age from about 65 years upwards, and with or comorbidities such as diabetes, high blood pressure, cardiovascular disease. Some countries have been doing 2 PCR checks on upper respiratory tract samples 24 hours apart. There has been some discussion around that, if that's too much or indeed not enough. Now, it's worth keeping in mind that a positive PCR result does not actually mean active live infection. You only know that if the sample can then be, the virus can be isolated and cultured from that same sample. As countries move more into a pragmatic approach because of high numbers of cases, for example, in the UK, we're moving into a situation where if you have a fever or a new cough that persists, then you're asked to self-isolate at home for 7 days. And you will not necessarily be tested, so have upper respiratory tract samples taken from you during that period of self-isolation. However, if someone is hospitalised now, even without an epidemiological travel link to, for example, China or Italy, but you have a respiratory infection that requires hospitalisation, which usually means you need some form of oxygen support, not necessarily even ventilation, then they will be tested for COVID-19. So Tony, I don't know if you want to add to that, because you've been at the front line in Glasgow. Over.
Hi, thanks, Gail. Yes, so I am also working as a clinician in a infectious disease unit in Glasgow. And as Gail mentioned, at the moment, because we still have relatively low case numbers, we are doing 2 PCR tests 2 days apart, and if they can go home if they're negative. But as the case numbers rise, and that's not really possible, and as Gail mentioned, we're really now asking people with mild flu-like symptoms to stay at home. I think that we will stop that quite quickly. There's also been a number of studies that have come out in recent days, a Lancet paper looking at risk factors for mortality that showed that amongst the survivors, the median duration of viral shedding is 20 days. I think the longest is 37 days. But again, as Gail highlighted, a positive PCR just means you can detect a bit of DNA. It doesn't mean that the person is actively shedding virus. So we're still finding out about that in terms of negativity. I just want to also make a comment. I think there has been interest in kind of therapeutic trials in Africa, I think, or low middle income countries. I think key questions we need to address before we even move on to therapeutics is to really understand prognostic factors in these settings, which might be completely different from China or Italy or some of the studies that are coming out just now. We know certainly for flu, you know, things like household crowding, TB co-infection, HIV infection will be important risk factors. So I think it's really important to identify context-specific risk factors, and perhaps, you know, the CCP is a very good opportunity, or using the data collection form will be a good way to try and characterize what those risk factors are in their individual countries. And then if it is possible to use that as a platform to look at clinical trials. I'll hand back over to.
Thank you, Tony, that's brilliant. You actually segued that really well, because I think the question of disease characterization first seems to be coming through really clearly on what we're hearing for everybody, and that's going to be so important to understand how this, you know, if case numbers increase across Asia and Africa, then getting these the disease characterization protocol put into place so that we can really understand those questions around what difference co-infections make and what the comorbidities might look like in different settings. But then, of course, we're in the situation of then having a window in which to do research. So I don't think, if people are interested in beginning to set up for clinical trials, that's all well and good as well. And obviously trials can happen on many different types of intervention, including you know, messaging and behavioural change and that sort of thing as well. We've only got a few minutes left, so I'm keen to give anybody the opportunity to talk who would like to. I don't know if there's anybody on the call who wants to make a comment or ask a further question, because we've, especially, I think some of these surveillance issues are really key. People we haven't heard from yet, who are maybe from Asia as well. Maybe you want to pick it up. Have you? Can you perhaps talk to the surveillance activities that are going on? I think this is one of the common questions we seem to be getting are, well, it's really interesting in countries where they're not reporting any cases. Is it because there aren't any cases, or is it because case detection isn't happening? And I just wondered if there was anybody who wanted to comment to that, about how widespread surveillance is happening. You know, Tony just explained what they're doing in Malawi, we've heard from Kenya, but I just wonder from some of the other countries online if you know about any of the surveillance activities that are ongoing. And obviously any last comments before we wrap up with next steps.
Hi, this is Pei Young here.
Go ahead.
I have two questions for the panelists as well as the members in the audience members. So we have a question about the ISARIC. Have you got a data dictionary that has been developed? And that's a question from Naomi, our data manager. And the second question is from me. Is anybody doing any qualitative or survey studies on, let's say, impact of travel restrictions?
Hi, thanks. Laura's working on the data dictionary. So Laura Merson, who I think quite a few people will know, is the ISARIC COVID-19 data platform manager. And then regarding the social science, so not as far as I'm aware through ISARIC, but it is quite a strong feature within GoARN research. And I think you're plugged into them as well with Nina Gobat and Lena Moses. And but certainly, I mean, we'd be delighted to learn anything there was to learn, in particular about community engagement as well for research. And it was great to hear someone on the line from the Kenyan Red Cross, because I'm also the deputy chair for GoARN, and we really appreciate our membership from the IFRC and ICRC, and I very much see the opportunity to reach out at community level through the Red Cross volunteers, because they are our eyes, ears and mouth to the community, and so I think there's a great opportunity there as well. Over.
Thank you, Gail. If anybody else has got any comments, please raise your hand before we wrap up. But just to add on from that, we're doing the same call again at 3:30 this afternoon, and we have the team from Theo Cruz on that call, and also a team from Honduras. And I know that they're setting up some of the qualitative social science work around this. And we're also linking this all to the MESH network, which is all around community engagement messaging. So there will be strong efforts to share the social science work, which always needs to go hand in hand with these clinical studies. So that's a given. I'm just looking to see if there's any hands up. Otherwise, I'll begin to wrap up. This has been tremendously helpful. Please take the opportunity to add anything onto the Q&A button on here. We will write up all the comments on a forum on here. And I think the plan is lots of you have been asking outside of this on our email system about how you can get involved and what resources are there. I think we can't say strongly enough, first go-to place is the WHO website, especially for putting in place all the immediate public health requirements and surveillance and case detection, case management, and so on. And then this is about working with ISARIC and WHO, GOAN and others to try and implement a research response. So I think what we're going to try and do from this call is to pull together maybe some working groups. So do volunteer to take part and get involved. And we really hope to run a series of these calls, perhaps on different topics going forward. So if you could message us with which topics you think would be useful to cover. Obviously, we've got some nice clear headings have come from this call, but if you can also let us know, we can go ahead and begin to set up some calls, and hopefully some of you might come forward and offer to coordinate those and put working groups together. And we can make sure that all of these feed back into ISARIC and WHO, so there's no duplication, it's all streamlined, and it's all around having, all using shared standards and forms so that data is high quality and can be shared. So I think that's probably taken up our time today. Are there any final comments from the panelists? Over.
Hi, Trudy. I think this is really wonderful. I really appreciate this initiative. I look forward to the resources and to see how we can be involved. I know we need to do clinical trials, but we are also very aware of the health of the people, and we can see a greater role for managing the panic, but also being aware of what is happening and being able to provide the information. Thank you so much.
Thank you, Dorcas. Is anybody else, or we want to wrap up? And I think it's just, Ambrose made a really great point earlier about our role as scientists in having, we all have our part to play about translating this. The politicians have a job to plan for the worst and make decisions, and I think we all have a role to impart the facts and put those in context, and I think that's just absolutely critical when you're seeing all of the rumours and misinformation. I think I couldn't second that enough, Dorcas. So Charles, do you want to speak?
Yeah, so just maybe also to say thank you for organizing, because I think it's really, really important that we have such a forum to speak and perhaps see how we can actually link already planned studies maybe and make them stronger by including other additional questions without having to incur so much effort. I had a question about case definition, which has been hanging around my head for some time. At the outpatient, the inpatient, and perhaps when contact tracing, it's really unclear to me what the case definition should be. I don't know whether any members in the panel will be interested to provide some guidance there.
I think that's our ISARIC team will be very happy to pick up that question, because that's so fundamental.
Yeah, so so the case definition, I think most people have probably been following what WHO have been putting out as a case definition, and what eventually, and so it has fluctuated as it did in China, and often case definitions do change as you gain more information, understand if you're dealing with a spectrum of disease, and how that matches with your healthcare capacity to cope with the different phases of the outbreak. So I think the first thing I would suggest is for you to liaise with whoever your most local public health officer is, and also probably your WHO country office, and then to have a look at the ISARIC tools and see what you think. But I think you're quite right. It's always best to try and align and have at least a national approach, and where possible, an international approach. Over.
Thank you for that answer.
That's great. Okay, well, I think we've gone just a little bit over time, but we were getting everybody to dial in. So thank you everybody for listening into this. We're going to try and capture it as much as we can. We've got another one of these this afternoon, so I think we can bring all of it together and have and we'll make public all these comments. And it's just really useful to have everybody together in this forum. So please all take part, keep contributing, and put forward your suggestions for topics that we can talk about next. So that's closing the meeting. Thank you very much, everyone, and especially to our panelists.